Hello everyone, welcome back. First, we will go through the trauma MCQ I shared with you in community post, and then we will discuss the pulmonary embolism topic with updated guidelines. So, this is the MCQ I shared with you. A 20-year-old male brought to the emergency department after a motorbike accident. He is restless and complaining of severe shortness of breath. Examination reveals respiratory distress. His pulse rate is 138, BP 78/50, and oxygen saturation is 84. His chest X-ray is shown below. What is the most appropriate immediate management? Option A, pigtail catheter aspiration. B, insert an intercostal chest drain. C, perform urgent needle decompression. D, give intravenous fluid and analgesics. E, intubate and ventilate. What is the answer? So what happened here? The patient had a history of trauma, a motorbike accident, and the patient is unstable. His BP is 78/50, pulse rate 138, oxygen saturation is only 84. So he is unstable now. And what about the X-ray? Is it normal? No, it is not normal. What is the abnormality? Here you can see the left side of the lung has collapsed. How you can identify that? You can see the lung markings or the normal vascular markings only up to this level. See, what is this white structure, white line? Visceral pleural line. Only up to that you can see the lung markings. After that, between this visceral line and the chest wall, only a black shadow is there. What is that black shadow? Air. So there is pneumothorax on the left side of the lung. And what about right side? There is lung markings up to the chest wall level, and the costophrenic angle is normal. So there is no pneumothorax or pleural effusion. And what else you can see? What about the trachea position? Is it central or displaced? It is minimally displaced towards the right side. See, trachea is minimally displaced towards the right side, and there is a minimal shift of mediastinum towards the right side. So here is a minimal shift of mediastinum towards the right side, most probably due to this pneumothorax. So what is the condition? It is an evolving pneumothorax, tension pneumothorax. So diagnosis is tension pneumothorax or decompensated pneumothorax. It is not spontaneous. Why? There is a trauma content. The trauma is the cause. That is not spontaneous. So it is a traumatic pneumothorax first, but it is now evolving as a tension pneumothorax. Okay, so the diagnosis is tension pneumothorax. So what is the management of tension pneumothorax? What is the immediate management? Urgent needle decompression that we discussed in our previous class. So the management of tension pneumothorax is urgent needle decompression. First you will do that, then we will give supportive management, and the definitive management is what? Intercostal drainage. So what is the answer? Option C, perform urgent needle decompression. This is the answer for this question. What about pigtail aspiration? This is usually done for unstable cases of primary spontaneous pneumothorax. For the secondary spontaneous pneumothorax, actually this will not be that much effective compared to the intercostal drain. The intercostal drain will be the definitive management that we'll do later. What about intravenous fluid and analgesics? They are supportive management that is needed in this case, but only after urgent needle decompression. What about intubation, ventilation? Contraindicated before decompression. That also we discussed in our class. So the diagnosis here is tension pneumothorax. The cause is trauma, traumatic pneumothorax, and it is evolving as tension pneumothorax. See, in these type of questions with a background of trauma and the patient complaining of shortness of breath or respiratory symptoms and showing any signs of hemodynamic instability, you should always suspect what? A tension pneumothorax, because that is a life-threatening condition and usually it is diagnosed clinically, and you should read the symptoms and signs of tension pneumothorax. What are the signs on general appearance? For example, distended neck veins. What is the trachea position in tension pneumothorax, and the chest findings, inspection, palpation, percussion, and auscultation. All these things you should read. And so it is an important topic for your exam. So the next topic, pulmonary embolism. Usually AMC will ask about investigations and management. For example, what is the next best step? What is the definitive management? What is the best investigation? Like that, they will ask questions. And you need to know a step-by-step management of pulmonary embolism, and for that first you need to understand some criteria, because these criteria are needed for categorizing patients based on their risk, either to high risk or low risk. So we call that assessment, the initial assessment, as the pulmonary embolism probability assessment. So the old one is Wells criteria, and for better and easier assessment now there is simplified Wells criteria, and there are several components in the simplified Wells criteria. What are they? Clinical signs and symptoms of deep vein thrombosis, immobility or surgery in the previous 4 weeks, previous venous thromboembolism, hemoptysis, malignancy, alternative diagnosis less likely than pulmonary embolism, heart rate more than 100 beats per minute. These are the components. For each component, if they are positive, you will give 1 score. And if the value, the total score is more than or equal to 2, you will categorize the patient in likely group. So that means the patient likely have pulmonary embolism. So the patient is in high risk. Okay. If the value is, the total score is 0 or less than 2, 0, 1 or less than 2, you will categorize in unlikely group. So that is simplified Wells criteria. There is another score, simplified Geneva score. They are given by the RACGP. But usually we will follow the simplified Wells score. So if you categorize the patient into high risk, what is the next step? If the patient is in high risk, what is the next step? You will do imaging for that patient. If the patient is in low risk or in unlikely group, what is the next step? You will apply something called PERC rule to that patient. What is PERC rule? Pulmonary embolism rule out criteria rule. So you will apply that rule to the patient if the patient is in low risk category. So what are the different components of PERC rule? Age less than 50 years, pulse rate less than 100, saturation more than or equal to 95, no hemoptysis, no estrogen use, no surgery or trauma within 4 weeks, no previous venous thromboembolism, no unilateral leg swelling. These are the different components, and these are the components you apply on a patient who are in low risk. So what are they? Good or bad? Good components, right? So if answer to any of these is absent, if any of these components is absent, the PERC score, the total PERC score will be more than 0. Then you will do D-dimer to that patient. That means if the PERC is positive or the score is more than 0, you will apply D-dimer. You will do D-dimer to that patient in PERC positive cases. So this is the flow chart from old RSAGP guidelines where the same thing they are showing. If the well score or the simplified well score is showing the patient as high risk, then you will do imaging. If the total well score is less than or equal to 4, or simplified well score is less than or equal to 1, you will apply PERC rule. If the PERC rule is negative, you will exclude pulmonary embolism. If the PERC rule is positive, you will do D-dimer. If D-dimer is negative, you will again exclude pulmonary embolism. If the D-dimer is positive, you will do imaging to that patient. These are from latest RSAGP guidelines. The same thing. If you apply the simplified well score or Geneva score to a patient, 2 categories, pulmonary embolism likely or pulmonary embolism unlikely category. And if likely, you will do imaging to that patient. And if the patient is an unlikely group, you will apply PERC rule. If no to any of these components, you will do D-dimer. And if positive, you will do imaging. If negative, no further imaging is required. If PERC rule is negative, again, you will not need any further investigation on that patient. So what is D-dimer? D-dimer is a degradation product of cross-linked fibrin, and it has high sensitivity but low specificity for acute venous thromboembolism, and it is always elevated in acute thrombosis and also in other conditions including sepsis, malignancy, pregnancy and trauma. So it is not specific for acute venous thromboembolism, but it has high sensitivity. So what are the different imaging modalities for pulmonary embolism? CTPA and VQ scan. What is CTPA? CT pulmonary angiography. VQ, ventilation perfusion scan. Which is better? CTPA, which is more sensitive and specific than VQ scan. A negative CTPA scan can exclude the pulmonary embolism. But there are some disadvantages. What are they? They have radiation risk, and we need contrast. So because of these 2 reasons, we can't use this for women of reproductive age group and in pregnant women and for patients with impaired renal function. So in these cases, we can go for either ventilation perfusion scan or some other investigations. So ventilation CTPA is the best investigation compared to VQ scan. Here another important point you need to keep in mind is about pregnancy. Pregnancy is a special scenario because of overlap of symptoms with the physiological symptoms of pregnancy. So there is an inability to use standard pretest probability score and consideration of radiation exposure to both mother and fetus. So there is some overlap of symptoms in pregnancy with the physiological symptoms of pregnancy, and we can't use CTPA in pregnant ladies even if we have a high suspicion of pulmonary embolism. Another thing is there is physiological increase in D-dimer in pregnant patients. So that is a special scenario. So what about Doppler? Lower limb Doppler. It has a high positive predictive value but low sensitivity and low negative predictive value, and it should only be used for non-high risk patients with relative or absolute contraindications for CTPA. Another important point, ultrasonography alone is not able to rule out pulmonary embolism. Another investigation, echo. Echo can be used to aid diagnosis in hemodynamically unstable patients with high clinical probability of pulmonary embolism by detecting right ventricular dysfunction. For detection of right ventricular dysfunction, we use echo. So these are some other investigation we can use in pulmonary embolism case. See, these are the risk factors for venous thromboembolism. It is divided into hereditary and acquired risk factors. Acquired is again divided into strong, moderate and weak risk factors. There is another classification, reversible and non-reversible risk factors. So you just read those risk factors from the guidelines. I am not going into details in this session. So what is the initial management? You will give oxygen if patient is hypoxic, and you will give supportive care, and the definitive management anticoagulation is indicated in almost all cases. That will prevent thrombus extension or recurrence. Do not anticoagulate if patient is low risk or if there is isolated subsegmental pulmonary embolism or no proximal DVT, or if patient has high risk of bleeding. And finally, you will refer the patient to hematology. Some points on anticoagulation. You will the first preferred anticoagulant is direct oral anticoagulants because there is fewer interactions and there is no need of routine monitoring and there is lower bleeding risk. For APS, antiphospholipid syndrome and morbid obesity, or for severe renal impairment cases, we will give warfarin. And for pregnant patients, breastfeeding or unresected luminal or GI or GU malignancy, genitourinary malignancy, you will give low molecular weight heparin. In cancer-associated pulmonary embolism, you will prefer direct oral anticoagulation. And the duration of anticoagulation is 3 to 6 months for all patients initially, and stop after 3 to 6 months if the pulmonary embolism is provoked one or by major reversible risk factor. Continue the anticoagulation if patient has 2 or more unprovoked venous thromboembolism episodes, or if the patient has persistent non-reversible risk factors such as malignancy or antiphospholipid antibody syndrome. Thrombophilia testing usually not recommended routinely at presentation, but can be considered if patient is less than 50 years with family history or if there is any history of unprovoked pulmonary embolism. Follow-up imaging is usually not recommended. Another important thing, CTEPH. What is that? Chronic thromboembolic pulmonary hypertension. chronic thromboembolic pulmonary hypertension, which is an uncommon complication of acute pulmonary embolism that is associated with significant morbidity and mortality. You just understand the name of complication, and we need investigations such as echo to ruling out that. So here is one question for you. A 65-year-old man undergoes left hemicolectomy for colon cancer. 4 days after the surgery, he suddenly develops dyspnea. On examination, he has a blood pressure of 110/70 and heart rate 110 and respiratory rate 22. He is afebrile. Which of the following is the best diagnostic modality to confirm the diagnosis? Options A, pulmonary angiography. Option B, D-dimer. Option C, chest X-ray. Option D, ECG. Option E, MRI. What is the answer? So what is the first step? You should first do a probability assessment on this patient to categorize the patient into high risk or low risk group. How can you do that? By applying simplified well score. Here the patient has history of left hemicolectomy for colon cancer 4 days back. Now his heart rate 110. So by applying this, his heart rate more than 100, so 1 score. Surgery history there, so 1 score. And malignancy is there. So his total score will be more than or equal to 2. So he is in high risk. So what is the next step? For confirmation. The question is about confirmation. What is the diagnostic modality to confirm the diagnosis? What is the next step? CTPA. So answer A, pulmonary angiography. So answer is A. When recent major surgery in history and pulse rate 110 and the patient has history of malignancy, so his well score, simplified well score is more than or equal to 2. Therefore, pulmonary embolism should be considered likely in this patient. And the next step would be imaging studies, either VQ scan or CT pulmonary angiography. Generally, CTPA is preferred over ventilation perfusion scan because it is often readily available and it is highly sensitive and specific than VQ scan, and it is more convenient to the patient. Unlike VQ scan, underlying lung disease evident on chest X-ray does not significantly affect the specificity of the test. So usually before VQ scan, we will do a chest X-ray to rule out underlying lung pathologies, because if X-ray is abnormal, there will be a false positive result for VQ scan. So we will do a chest X-ray before VQ scan. We will prefer chest X-ray before VQ scan. So underlying lung pathologies will not affect a CTPA report but will affect a VQ scan. And there are the drawbacks like radiation for CTPA. CTPA is always a method of choice except in the following patients: women of reproductive age group less than 55 years, poor GFR less than 40, or those with progressively declining renal function, because we use what? Contrast. And if there is any allergic reactions to contrast media, we will use another investigation. So that's all for today. If you have any queries or suggestions, please feel free to add them in the comment section. And if you like the content, like, share and subscribe to my channel. And thank you for watching.